Hey y'all, my name is Mitch Tan, one of the Cardiac Electrophysiology Fellows here at the Texas Heart Institute in Houston, Texas. As a general cardiology fellow stepping into the EP lab for the first time, I still remember how daunting a task it was to learn and understand what I was seeing. This video series is designed to introduce concepts relevant to the EP lab and electrogram interpretation, and to do so in palatable bites, ultimately building to you practicing electrogram interpretation on your own. My hope is that by slowly layering on detail and understanding, the basics of electrophysiology will seem easy by the end of the video. Now time to start an introduction to the EP lab. All right, firstly, I'd like to remind everybody, one of my favorite quotes that I've heard is a quote by Benjamin Franklin, "Tell me and I forget, teach me and I remember, involve me and I learn." I'm hoping that this talk is an interactive talk that'll keep you participating and engaged, and hopefully through this will help you learn. So firstly, no relevant financial disclosures. So what are the goals of our talk today? First, to establish the utility of intracardiac electrograms and why we do an EP study in the first place. Next, to introduce the basics of electrogram interpretation. Then, after that, we're going to practice electrogram interpretation in identifying meaningful observations. We're going to begin to use our observations to derive physiologic conclusions. So why is learning EP initially challenging? Well, compared to other concepts in cardiology, EP can seem less intuitive at first. For example, even before you started your medical training, most of us have encountered something like this. Now, whether you've encountered this or helped to cause something like this, we've all seen and can understand intuitively what a flow-limiting obstruction causes. So, as a cardiology fellow, when you encounter something like this at work, we can intuit what the problem is and what the solution may be. But fewer of us have encountered something that looks like this. Now, this is just a simple screenshot from our electrogram monitor. So, when we do encounter something like this for the first time, we can feel a bit confused. And when we see something like this, it can feel like we're looking at this. But with the right preparation, we can start to develop the vision. And all of a sudden, all the signals on the screen can actually start to paint a picture. And that can turn into this. So when we step into the EP lab, what we're doing is we're starting to think about intracardiac electrical recordings. But the first question goes, why do we need more than just a surface ECG? Well, let's review what a 12-lead ECG can show us. Firstly, a 12-lead ECG can show us when things are normal. A 12-lead ECG can also be very specific in identifying certain arrhythmias. For example, what rhythm is this? And feel free to pause the video at any time if you need to stop and think. Well, looking here, we can start to identify the presence of upright flutter waves in V1 and negative flutter waves in the inferior leads, 2, 3, and AVF. This constellation of findings, for those of you familiar, we know is consistent with typical atrial flutter. So while the surface ECG tries its best, sometimes it's not specific enough. For example, take a look at this. Now, in this case, we know that the 12-lead shows us an SVT, but the more practical question is, which SVT is it? So why are there limitations to the surface 12-lead? Well, if we think about how the surface 12-lead is formed, this is based on electrical recordings based on electrodes that are positioned around the heart. Electrical activity occurs between these electrode pairs and is seen or recorded. Because the electrode pairs are positioned around the heart, their field of view is large. And the signals recorded here represent the sum of all electrical activity in between. So, with all that, we need a way to enhance our testing, to look a bit closer. Introduce our friends, the intracardiac electrodes. In an electrophysiology study, we utilize catheters with multiple electrodes, and we place them in strategic locations within the heart. Here's an example of one. These electrode pairs are closely spaced and thus have a local field of view. Rather than being from shoulder to shoulder width apart, these are only millimeters apart. Compare this to the widely spaced electrode pairs of our 12-lead ECG, which provide global information. Now we can see how intracardiac electrodes provide very specific and local information. So what are the goals of an EP study? Well, the goal of an EP study is to help diagnose abnormalities in cardiac conduction. But before we can diagnose the abnormal, we should first identify what normal conduction is. Let's start by reviewing what information we can derive from an ECG of normal sinus rhythm. In an ECG, we have a lot of explicit information, things that we can see, such as the P wave, which we know reflects atrial depolarization, our QRS complex, which represents ventricular depolarization, and then our T wave, which represents ventricular repolarization. But we also know that there's a lot more to this than just the explicit information. We know that there's information in the timing of events, and therein lies the implicit information within our electrical recordings. The intervals that we're going to describe here represent discrete events in the electrical activation of the heart, such as the PR interval, which represents the depolarization of the first atrial myocyte, but also includes conduction through the AV node, as well as conduction down the HIS Purkinje system. And the QRS interval, which represents depolarization of the first ventricular myocyte all the way to depolarization of the last ventricular myocyte. We know that there's a lot that we can infer about the width of this QRS complex. Narrower QRS mean that there's faster activation of the ventricle, while wider QRS implies slower activation of the ventricle. And through this, we can start to come to conclusions about the health of that ventricle, whether it be the presence of antiarrhythmic drugs slowing conduction, the loss of the HIS Purkinje system utilization for ventricular activation in bundle branch block, or the presence of scar related to MI. Now, I'd like us to examine atrial activation a little more closely. So let me ask you this. Have you ever thought about how the atria depolarize? Does it happen simultaneously, or does it happen sequentially? We know that there are two of them. Well, if you said sequentially, that's the right answer. But more importantly, why does this occur? Well, as you may or may not know, the atria are actually electrically isolated from each other except for 3 locations. This includes Bachmann's bundle, a thick muscular band-like structure across the anterior aspect of the right and the left atrium, the fossa ovalis, and the os of the coronary sinus. Here's a little cartoon that I've drawn showing our right atrium and our left atrium. This structure here, labeled A, is Bachmann's bundle. This B here is the fossa ovalis, and here in this purple is the os of the coronary sinus. Now, in a typical sinus depolarization, the sinus node fires, setting off an electrical wave of depolarization that starts in the high right atrium. This eventually travels from the right atrium, travels from superior to inferior and from lateral to septal until it encounters one of these 3 portals of communication and conducts from the right atrium to the left atrium. So let's review atrial activation. Even if you didn't know the specifics of interatrial activation that we just reviewed, you've probably seen it reflected in other ECG criteria. Take, for example, here, the criteria for atrial enlargement. These are things that we've probably started to get familiar with as medicine residents. When we look at the criteria for right atrial enlargement, we see that this focuses on the P wave amplitude in the early component of the P wave. In left atrial enlargement, we see that the emphasis is on larger P wave amplitudes in the late component of the P wave. And if we remember that time is our x-axis, then we know that these abnormalities in the P wave reflect sequential right to left atrial activation. So even if you didn't know the nuances of right to left interatrial activation, we've already seen it reflected in some of the criteria we're familiar with. The point that I'm trying to make in the last few slides is that in electrophysiology, timing matters. And there's so much that we can derive from the timing of events, a lot of implicit information that better educates us on the physiology at hand. So when we step into the EP lab, the first thing to know is that electrophysiology requires an adjustment in emphasis. Compared to the major issues in the interventional world, which focus on changes in the y-axis, in the EP lab, we look for explicit and implicit events based on timing along our x-axis, and we're asked to explain how and why these arrhythmias occur based on this information. So back to our electrogram monitor. Why are electrograms intimidating? Well, there's lots of information displayed. The information is updated live and in real time. This can be very daunting at first. Small differences in timing matter, and subtle differences in signal morphology can have important implications. And lastly, it takes time to learn in 4 dimensions. Here's a video of a biatrial flutter. Now, while we have a lot of technology these days and complex and sophisticated electroanatomic mapping capabilities, at the heart of it, the software is just rendering or visualizing the information that's stored within the electrograms. Ultimately, what we're doing is learning how to create these images in our own mind based on our understanding of electrograms and our familiarity with catheter placement. So, how do we learn to interpret electrograms? Well, I'd like to cover a few key topics here. First, we'll go over the anatomy of the electrogram monitor. We'll go over where we place our catheters. Then we'll review our cardiac anatomy with a little bit more specificity. And lastly, after all that, we'll learn how to interpret our signals. So let's start off with the anatomy of the electrogram monitor. So here's our little inset screenshot of an electrogram monitor. As we've discussed before, the x-axis on the screen represents time, and along our y-axis we see a number of electrical channel recordings. At the very top, focusing on our surface 12 lead, and then our intracardiac electrodes here in the bottom half of the screen. The other thing to know is that when you step into the EP lab, the paper speed we use may change from what you're normally used to interpreting on a 12-lead ECG. For example, the standard paper speed for a surface ECG is 25 millimeters per second. But in the EP lab, we can range the paper speed from 25 up to 200 millimeters per second. This gives us better specificity in measuring intervals and detecting small changes in the timing of events. Faster paper speeds, though, lead to a more broadened or slurred ECG appearance because the paper is moving quicker. And that's one thing you'll need to familiarize yourself with when you step into the EP lab, is that the paper speed may be different at the time you're observing a study. So next, let's focus on catheter placement. We've reviewed the typical activation of the heart. And if we're remembering, the purpose of an EP study is to help identify abnormal conduction. So, to identify the abnormal, let's first review what normal is. We know that in the typical heartbeat, the heart starts with atrial depolarization, and the P wave represents depolarization of the first atriomyocyte. After that, we get right atrial to left atrial intraatrial depolarization, and simultaneous sometimes with that, we get propagation of this wavefront and conduction through the AV node. After the wavefront passes through the AV node, conduction occurs down the HIS Purkinje system. And last but not least, leads to ventricular depolarization. In a standard EP study, we utilize 4 catheters. These catheters are placed to help evaluate for normal conduction and activation of the heart. We place catheters in the high right atrium to help approximate the SA node, in the coronary sinus to give us a marker of left atrial activation without the need for a transeptal puncture. We place a catheter across the tricuspid valve annulus in the region of the HIS bundle. And last but not least, we also place a catheter in the RV apex to give us local information and pacing capabilities from the right ventricle. These catheters are placed strategically, once again, to help us assess for typical activation of the heart. And during tachycardia, the positioning facilitates diagnosis of arrhythmia mechanisms. Now, let's go over cardiac anatomy. Here's a little cartoon that I've drawn of the 4 chambers of our heart. Here's our sinus node, our AV node, the os of the coronary sinus, and as you remember in our anatomy, the os of the coronary sinus opens into the coronary sinus, and the coronary sinus is the venous structure that wraps around the mitral annulus, from the inferior aspect to the lateral aspect all the way up to where it joins the AIV, which runs parallel to the LAD. And the HIS bundle here, which penetrates through from the atrium into the ventricle, the right bundle branch, and the left bundle branch. And this region right here is a region that's very important for those in electrophysiology. Here's another cartoon that I've drawn of this area. And this area is known as the triangle of Koch. The posterior aspect of this triangle is marked by the tendon of Tadaro. Now, this is not something we can see on fluoroscopy or during an EP study, but marks the posterior aspect of this region. The inferior border of this triangle is marked by the os of the coronary sinus, and the anterior aspect of this triangle is marked by the tricuspid valve annulus. So taking all these 3 into account, here we can start to visualize what appears to be a triangle. This triangle is important because at the superior vertex of the triangle lives the compact AV node, and at the inferior vertex of this triangle lives the region of the slow pathway. Very important for us in EP to identify one and stay away from the other when it comes to ablation. So reviewing here all of our important cardiac anatomy, now we can start to see where we place our electrode catheters. Once again, we place a catheter here in the high right atrium, which approximates sinus node activity. We place the HIS catheter across the tricuspid valve, which helps us to measure the HIS bundle activation. Our CS catheter observes the inferior atrial septum and extends out to the left lateral atrium. And our RV catheter provides a means to pace the ventricle and observe local RV activation. Now let's go over catheter nomenclature. Whether your catheter has 2 electrodes or 20, the nomenclature is still the same. The distal-most electrode is always named electrode 1, and the proximal-most electrode starts to count up, in this case, electrode 10. Notice how they're grouped in pairs. Now let's go over the working views of the heart. Just like in heart catheterization, we use the RAO view and the LAO view. But here we have some beautiful gross anatomic specimens from the recent publication by Shumpei Mori and Dr. Shiv Kumar out of UCLA. Here in the RAO view, we see how the leftmost portion of the screen represents the posterior aspect of the heart, while the right side of our screen in the RAO view describes the anterior border of the heart. In the LAO view, the left and the right each represent a lateral aspect of the heart, while down the center of our screen, here we see the septum. When we take our catheter position for a general EP study, we can see how they sit in the RAO view, and here we can see how they're inset in our LAO view. Notice here in the LAO view how the HIS catheter and the RV apical catheter stay on the RV side of the interventricular septum. And notice how the coronary sinus clearly breaks through the septal demarcation and is measuring the left atrium, passing through the area of the interatrial septum via the coronary sinus. Now through these images, I hope you have a better appreciation of where our catheters live both on fluoroscopy and in a gross anatomical specimen. Now before we go into signal interpretation, let's take a brief moment and just talk about signal creation. Now here's a cartoon of a bipolar electrode pair. Now, each of these electrodes records their own unipolar signal. And just to review, unipolar signals are generated by the interaction of a wavefront approaching or moving away from an electrode. Recall that as a wavefront approaches an electrode, a positive deflection is recorded. And as an electrical wavefront moves away from an electrode, a negative deflection is recorded. Now the point in time where that wavefront is directly underneath that unipolar electrode is represented by the transition from a positive to a negative deflection, and the point of that slope which is the most negative. Now while we've talked about unipolar recordings, the majority of the time our electrogram monitor displays bipolar recordings. And these bipolar recordings are created based on the individual unipolar signals that are recorded, just like we went over. Now, the signals between the two paired electrodes are subtracted from one another and used to generate a bipolar electrogram. Now, we can talk about signal interpretation. So, what are the things we look for when interpreting an electrogram signal? Well, the first thing that we might look at is the signal amplitude. These are changes in the y-axis and represent voltage. These voltage changes can represent the health of a tissue. Big voltages for healthy conducting myocardium, small and fractionated voltages for diseased tissue. The next thing we can look at are timing of electrical events, timing along our x-axis. And the last thing we might look at is what the actual signals look like, or the signal morphology. This can tell us a lot about the nature of the signal and what it represents. In fact, let's start by focusing on signal morphology. The first type of signal that we need to be able to identify is what's called a near-field signal. Near-field signals are sharp and narrow, and near-field signals represent local electrical activity, electrical events that are happening in the location of our bipolar electrode pair. Now, it's very important for us to be able to distinguish near-field signals from these. These are far-field signals. Far-field signals are broad and wide. Far-field signals represent distant electrical activity that's still able to be detected by our bipolar electrode pair. They do not represent local activity, and it's very important that we're able to distinguish these two from one another. Now let's take a look here at some real electrogram recordings from a patient in our EP lab. And we'll take a focus here at the bottom on our coronary sinus catheter. And I want us to take a look at the signals that we see here on the left and compare them to the signals here on the right. Now, let me ask you, what do you think that these signals on the left represent? That's right, these are near-field signals. They're sharp and they're narrow. Compare these to the signals on the right, which are broad and can be of lower amplitude. These are far-field signals. Our coronary sinus catheter is located within the coronary sinus, which sits along the mitral valve annulus. So it's capable of recording local atrial signals, but still close enough to the ventricle to see distant ventricular activation. So here we can see what the catheter is looking at. Local atrial activation followed by remote ventricular activation after that wavefront makes it through the HIS Purkinje system and we have ventricular activation. Now let's take this a step further. Once again, we know that these here are near field signals and these here are far field signals. So the next question is an exercise in naming these signals and making sure that we know what these events represent. Once again, these are local recordings. So if there's ever any question on what the electrical signals locally represent, what we can do is we can compare them to our global reference, our surface 12 lead, located up here. Looking closer, we see that those first signals coincide with a P wave. And we can see that the second signal coincides with a QRS complex. Putting it all together, we may now describe these signals as such. The signal on the left represents a near-field atrial electrogram, while the signals on the right represents a far-field ventricular electrogram. This is the verbiage we use in the EP lab, and it's important that you get familiar with this. So, we've talked about signal morphology. Next, let's focus on activation time. So far, we focus on the importance of individual electrograms. But the beauty of the EP lab and the things that start to become more intuitive are when we start to interpret electrograms in groups. Here's a little cartoon of a catheter activation sequence in our cartoon catheter. Based on the signals here on the left, what can we conclude about the direction of electrical activation relative to our cartoon catheter on the right? Feel free to pause the video at this point and think about it. Well, we can see that the timing of events starts at our distal electrode pair, 1, 2, and moves sequentially down towards our proximal electrode pair in 910. This represents an electrical activation wavefront moving from distal to proximal. See, that's not too bad. And vice versa, if we see an electrogram activation sequence like this, we can see that our earliest signal occurs on the proximal electrode pair in 910 and travels sequentially to our distal electrode pair in 1-2. So let's summarize what we've covered so far. Here's our electrogram monitor. We now know that each color-coded set of lines represents a specific catheter, whether our high right atrial catheter, our HIS bundle catheter, our coronary sinus catheter, or our RV apical catheter. And we know that each line represents a recording from a bipolar electrode pair. We now know that each catheter is placed in strategic locations within the heart, and that signal morphology can tell us if an event is happening locally or remotely. And lastly, what we covered is that the order of electrogram signals reflects tissue depolarization and the timing and direction of wavefront propagation. Here in this example, we see near-field atrial electrograms which start earliest on CS910 and move out to CS12. And we know that based on where this catheter is positioned, this reflects septal to left lateral atrium activation, as shown here. All right, time to practice what we've learned. Here's our first practice problem. We're going to start easy and we'll add some complexity and nuance as we go. I encourage you to pause the video, take your time and try to figure out what's going on, and then resume the video when you're ready to see the solution. Here's our electrogram monitor screenshot. So how best to go about this? Well, the exercise here is to correctly identify the order of activation and to practice in your mind's eye where those electrical signals are coming from. Start by answering what is the first recorded local event. I suggest by starting on the left side of your screen in the intracardiac electrode section and finding what's the first near field signal you see. And then after that, you can move from left to right, locating the next near field signal and answering the question, where does this event take place and what occurs next? Here, we see a near field atrial electrogram which starts earliest in the distal portion of the high right atrial catheter. We can envision this as an electrical signal starting in the area of the sinus node. Next, we see a near field atrial signal on the proximal aspect of the HIS bundle catheter, occurring somewhere in this area. So we can then infer that there is some atrial electrical depolarization starting from the sinus node and working its way down towards the area of the AV node. Next, we see a near-field electrogram here at the proximal aspect of the CS catheter, which continues, and we see a series of near-field atrial electrograms moving from the proximal CS catheter to the lateral CS catheter. All right, in our mind's eye, we can envision a wavefront of electrical depolarization moving from septal to lateral. And then, here, on the RV apical catheter, we can see a near-field ventricular electrogram, which coincides with our global surface QRS, thus representing ventricular depolarization. So, if I were to ask you how to describe this beat, what might you say? Well, we'd probably conclude that this is likely a sinus beat. All right, good job. So we started off on something easy, and time to practice a little bit more. Here's our next recording, now without the presence of the surface 12 lead and with no RV apical catheter. All right, so start on the left with the first beat and describe that, and then move on to the second beat. What do you see? We can see that we have a signal originating at the distal portion of the high right atrial catheter, just like the first beat. We see a near-field electrogram here on the HIS catheter, And then similarly, we see septal to lateral atrial activation along the CS catheter. If we look more closely though, we do have a marker for ventricular depolarization. We see far field ventricular electrograms on the catheters positioned near the AV groove, our HIS catheter and our CS catheter. So we know that the ventricle is being activated here, even if we don't have a catheter placed in the right ventricle. Well, if you said that the first beat represents the sinus beat, you'd be correct. Now, what's going on in the second beat? Well, going through our order of operations again and identifying the earliest near-field signal, we see that there is a near-field atrial electrogram originating at CS12. And CS12 is typically placed towards the lateral aspect of the left atrium. So in our mind's eye, or our cartoon here, we can see that the wavefront of depolarization originates somewhere in this region, at least based on the catheters we have placed. Looking at the order of near-field electrogram activations, we see now that the wavefront moves from lateral to septal in this direction before it reaches the area of the AV node. And here we see that our high right atrial catheter in this location is actually activated last for all of the near-field atrial electrograms we can see. We still see far-field ventricular electrograms here, showing us that our wavefront does make it down the AV node in the HIS Purkinje system, and the ventricle is activated. So how would we describe this second beat? Well, it comes early, and it's an ectopic atrial beat, so we should accurately describe this as a PAC. And more specifically, we can say that it's a PAC that originates in the left atrium. Where exactly it originates in the left atrium, we can't be certain, but based on our intracardiac electrodes, we can say that it's probably close to the region of CS12. All right, time for our third and final practice problem here in our introductory practice problem set. So here's our intracardiac electrode recordings. And one specific thing I'd like to point out about this recording is that the ablation catheter here is actually placed in the high right atrial position. So a little added complexity, but just know that ablation 1-2 and ablation 3-4 are the equivalent of high right atrium 1-2 and high right atrium catheter 3-4. So what is the first beat? Once again, we see near-field electrograms occurring here on this catheter. The MiFi electrodes are just other electrodes on the ablation catheter that are very, very closely spaced. These are present on the Boston Scientific arrhythmia system. Next, we see near-field atrial activation occurring at CS910 and traveling from septal to the left lateral atrium. And then we see a near-field ventricular electrogram on our RV apical catheter. Notice how this near-field signal on the RV apical catheter actually occurs later than the onset of the QRS. So, while the RV apical catheter gives us a local look at activation in the right ventricle, we know that ventricular depolarization actually starts somewhere else sooner than this. This is important because when we measure our intervals later in more advanced problems, we often measure the ventricular activation to the earliest ventricular activation on the surface 12 lead, which is the true representation of the first ventricular myocyte being depolarized. So this first beat, once again, represents a sinus beat. So what's the second beat represent? Well, let's take a look here at our cartoon and our intracardiac electrodes. So what we see here is a local ventricular electrogram that's recorded on our RV apical distal electrode pair. Next, we see a series of local ventricular electrograms that march their way up from distal to proximal along our RV apical catheter. Next, we see local ventricular electrograms actually recorded here on our HIS bundle catheter. A short time later, we see atrial activation. And atrial activation here is recorded near simultaneously, both on the proximal high right atrial catheter as well as the proximal CS910 catheter. The atrial activation sequence on both of these catheters shows simultaneous travel of this wavefront in both directions, like this. So what is this beat? This beat is a PVC. Notice how the atrial electrograms on our high right atrial catheter and our CS catheters happen simultaneously. And this is an important thing to realize. When the heart depolarizes, not every event occurs sequentially. Some things happen at the same time. Once again, parallel activation of the atria. Now, a more advanced question. Based on the signals you see here, where do you think our HIS catheter is positioned? Well, taking a look and enhancing, what we can see here in the first beat is that the atrial electrograms appear far field, whereas the ventricular electrograms appear more near field. Thus, the HIS catheter is likely positioned towards the ventricle because the activity that's seen more clearly or locally appears ventricular. When we look at the PVC, we can see the same relationship, that the PVC and the ventricular activation appears sharper and more near field, whereas the atrial activation that happens later looks more far field, low amplitude and broad. All right, well, you guys did great with those practice problems. Now, time to focus on a topic that I've intentionally omitted up until now. And the purpose of this is to sort of layer on complexity one layer at a time. Well, let's take a look here at our intracardiac electrograms. And here we just see another beat of sinus rhythm. But my question now is, what are these signals here? Zooming in, we know that the signals on the left reflect atrial depolarization, or our A's. And we know that the signals here on the right represent ventricular depolarization, or our V's. What about the discrete and near field signals that happen in between? Well, these signals here represent depolarization of our HIS bundle, or our H's. So the question is, why do we care about the HIS bundle? Well, here's a little cartoon that I've drawn to represent the AV node. One thing that might be surprising to you is that despite our sophisticated technology, we actually cannot directly measure the activity within the AV node. We can't see what's occurring inside the mountain. Instead, we utilize surrogate markers to approximate AV node conduction and AV nodal conduction properties. Pretend this cartoon train is our electrical wavefront in the atrium. We can measure when our wavefront disappears into the AV node. So we use the near-field atrial electrogram on the HIS catheter as the timing for when the wavefront is about to go into the mountain. And we can see when it reappears on the other side, in the region of the HIS bundle. Thus, this AH interval represents conduction through the AV node. So why is it important to record the HIS bundle? Well, it can be critical in our evaluation of conduction system health. We know that the PR interval represents conduction from the atrium to the ventricle. And after this talk, we know that more specifically, the PR interval actually represents two additional distinct events. Conduction through the AV node, represented by our AH interval, and conduction down the HIS Purkinje system, reflected by our HV interval. But without measuring the HIS, we can't know the contributions of each. Do we have a large AH interval and a short HV interval, reflecting slow conduction through the AV node, but normal conduction through the HIS Purkinje system? Or do we have a short AH interval, but a long HV interval, contributing to our long PR interval, which would imply more diseased distal conduction? But why is a long HV interval important? Well, we know that HV intervals greater than 100 milliseconds predict progression to complete AV block. especially in those patients who have chronic bundle branch blocks. This was a finding that was described by Mel Scheinman in 1982. Dr. Sharpen and his team evaluated 313 individuals with chronic bundle branch blocks, and they followed them for 3 years after acquiring HIS bundle recordings. They saw that progression to high-degree AV block was 12% in those with HV intervals greater than 70 milliseconds. And they saw that progression to complete AV block was nearly 1 out of 4 in those with HV intervals greater than 100 milliseconds. For context, a normal HV interval is somewhere in the realm of 35 to 55 milliseconds. Now what about this ECG? Pause the video and tell me what the rhythm is. All right, well here we can see a P wave, and here we can see another P wave, but only one of the P waves is associated with a QRS complex. And if we go on through the rest of the tracing, we can see that we have 2 P waves for every QRS complex. The most accurate way to describe this would be to say that this is an example of 2-to-1 AV block. So, the HIS bundle recording can actually help us differentiate the location of the conduction block in 2-to-1 AV block. Mattering on where the block occurs, whether it's in the AV node or more distally in the HIS Purkinje system, is critical for management and patient safety. Where does conduction block occur in each of the following? We know that in Mobitz type 1 or Wenckebach, where we see prolonging PR intervals before a dropped QRS, that this block occurs in the AV node. And here in Mobitz type 2, where we have a fixed PR interval before we have a drop beat, we know that this represents more distal conduction disease and that the block occurs in the HIS Purkinje system. So in 2-to-1 AV block, we can't tell, at least not based on a surface tracing alone. But with the help of a HIS bundle recording, we can localize where the conduction block occurs. Here at the top, we see a single surface lead, lead 2. Then we see a high right atrial intracardiac recording, a HIS bundle recording, and then our RV apical recording. Pause the video here and see if you can figure out where the conduction block occurs. Taking a look through our tracing, what we can see is that we have both a local atrial electrogram and a local HIS electrogram. Our wavefront is making it through the mountain of the AV node. So if it's getting through the AV node but not making it to the ventricle, we can conclude that block occurs infranodally or in the HIS Purkinje system. This is the equivalent of Mobitz type 2 block, and this alone is an indication for a pacemaker. Now what about this recording? Well, here we can see that there's a local atrial electrogram without a HIS electrogram on the portions where there's a dropped QRS complex. So we see that our wavefront is entering the AV node, but it's not making it out to the other side. This is a block that occurs intranodally within the AV node. So where does the block occur here? Well, in the first beat, we see a P wave and a QRS on the surface, but in the second beat, we see a P wave without a QRS. Looking down in our intracardiac electrodes, on our HIS catheter, we can see a local atrial electrogram and a local HIS electrogram. Thus, we can conclude that our electrical wavefront is making it through the AV node, but gets blocked somewhere either within the HIS bundle or the HIS Purkinje system before it can make it to the ventricle. But taking a look here at our third recording of our intracardiac HIS electrodes, we can actually see a split HIS, 2 local HIS electrograms. This is something that describes and represents diseased HIS bundle conduction. This is an example of intrahisian block, or block at the level of the HIS bundle. And we can see this too. Compare the AH interval in the first beat with the AH interval in the second beat. We go from long to short. And then looking at the third beat, we can actually see both components of the HIS recording. We see 2 H's, an H and an H prime, each representing a different portion of HIS bundle activation. The H for proximal HIS activation and the H prime for distal HIS activation. In our blocked beat, the second beat in the center, what we can see is that we see the AH timing representing block in the proximal HIS bundle. It's pretty cool, right? Time to move on to more advanced practice problems. It's time to introduce another concept here, and the concept is pacing maneuvers. If we look down here, we see pacing spikes or pacing artifact throughout the recording. We see that they are occurring here on the RV distal channel. And we see that these pacing spikes occur at an interval of 540 milliseconds. So, putting it all together, what these pacing spikes and interval recordings on the RV distal channel represent is RV pacing. And we're RV pacing at 540 milliseconds. That's at a heart rate range somewhere between 100 and 120 beats per minute. Now, let me ask you, while we're pacing the ventricle, what observations can you make? Now, let me emphasize a few things here. It's always good habit to start by looking at your surface leads when you're doing more complex electrogram interpretation. So we can see here that on our surface 12 lead, we see pacing spikes and we see a wide QRS complex. This does reflect that our RV pacing is leading to ventricular capture. But what else do you see? Well, we can see here that on the first and third beat, we have an atrial activation sequence that looks different than what we see here on our second and our fourth beats. Now try to explain that. What could these represent? Well, if we think about this from our cartoon perspective, we can see that on beats 1 and 3, the earliest atrial activation is actually occurring out here in the lateral aspect of the left atrium. And that for the second and fourth beats, these blue beats, that the earliest atrial activation is actually occurring here in the region of the AV node. So how do we explain that? Well, this can be explained by the presence of a left lateral accessory pathway. Beats 1 and 3, the beats in the yellow boxes, display what we call an eccentric activation pattern, or an atrial activation pattern that doesn't look like it's using the AV node. So we can see that these beats in the yellow boxes actually represent accessory pathway conduction, and that these beats here in the blue boxes represent retrograde AV nodal conduction. But why does it alternate? Besides activation pattern, what other differences are there between the two sets of beats? Once again, feel free to pause the video right now to stop and think about what might be going on. Well, looking here on the beats using an accessory pathway, we can see that our time from our ventricular pacing to our earliest atrial activation occurs at 200 milliseconds. And here on the third and fourth beats, we can actually see that the beats where the AV node is used for retrograde conduction actually take a longer time, 330 milliseconds. What can we conclude from that? Well, the first thing we can conclude is that VA conduction occurs more quickly through the accessory pathway than the AV node. Now, the thing that you need to know is that depolarizing wavefronts propagate to the tissue that is most easily available. They go to the path of least resistance and fastest conduction. So, if the accessory pathway conducts more quickly, but is only used some of the time, we can conclude then that the accessory pathway is unavailable or refractory on the beats where the AV node is used for retrograde VA conduction. Here, we've characterized the accessory pathway retrograde block cycle length, or the cycle length where the accessory pathway will no longer conduct one-to-one. Here is an activation map of this left lateral accessory pathway. Down here we can see that this is the LV apex. This white broad area is the mitral valve annulus. This is the left atrium. Over here to the left of the screen is the septum, and not pictured is the right ventricle and right atrium. And out here is the left ventricle and the left atrial free wall. Those spheres in the center represent the area of ablation that we perform to get rid of this accessory pathway. All right, time to go to our advanced practice problem number 2. Once again, we have a pacing maneuver, but this time, this is a little different. We see pacing artifact, but the pacing artifact in this example occurs on the high right atrial catheter. We see a paced impulse occurring at a constant cycle length of 600 milliseconds. Now, following this, we see a final impulse that's delivered at a shorter coupling interval, 380 milliseconds. This is called an atrial extra stimulus and is equivalent to us delivering a PAC that we have programmed specifically to come at 380 milliseconds. So now that we know what's occurring, that we're delivering a PAC, the question is, what observations can we make? Feel free to pause the video here and make any observations you can. Resume it when you're ready to proceed. Well, one of the first observations we can make here is that we have different timings between our atrial pacing impulse and the QRS complex on each beat. We can see this on the surface 12 lead. The time between the S1 and the surface QRS is 240 milliseconds when we pace the high right atrium at 600 milliseconds, or at 100 beats per minute. But after delivery of a PAC, we can see that this draws out to 420 milliseconds. So how would you explain the differences in conduction between the two beats? Well, we have intracardiac electrode recordings to help us. If we can identify the HIS electrogram, we can better identify how atrial to ventricular conduction occurs. Here are examples of our nice, well-measured HIS EGMs. And by measuring the AH interval in each of the beats, we can see the difference is due to AV nodal conduction delay. Our AH interval, when we're pacing at a constant drivetrain cycle length of 600 milliseconds, is 200 milliseconds. But after delivery of a PAC, we can see that the AH interval jumps out to 380 milliseconds. In contrast, the HV interval in both of these cases remains unchanged. The HV interval is measured from the HIS electrogram to the earliest ventricular depolarization we can see on the surface 12 lead. The difference in AV conduction time for each beat can be explained in one of two ways. We could explain it through decremental conduction within the AV node, something we know that the AV node is capable of. Or we could explain it by conduction down a structure with different conduction properties. Let's save this idea for later and finish evaluating the rest of our tracing. What else do we notice? Well, here, after ventricular depolarization, we see another set of local and near-field atrial electrograms. Let's describe it. Where does the atrial depolarization start? Well, we see a near-field atrial electrogram here on our HIS catheter. And the earliest atrial electrogram is seen somewhere in the region of 2-3 or 3-4. But in our mind's eye, we know that this is in the region of the AV node. We can see that the high right atrial and the CS catheters are activated later. And based on this, we can conclude that there's low to high and septal to lateral atrial activation. All right, time to put it all together. We've made several observations. And in EP, we combine the observations we make with our knowledge of physiology to derive conclusions. So how do we explain the observations in this tracing? Well, we've discussed the possible explanations for a prolonged AH interval. We could say that this is AV nodal decrement or use of an alternative conducting structure. But to explain our observations about AV conduction, we must also explain the genesis of this final atrial impulse. We know this impulse arises near the AV node. Thus, it could be due to a few things. It could be a PAC focus near the junction. It could be junctional ectopy, or it could be retrograde conduction up the AV node. If we see the same response consistently, is there a conclusion that is most likely of these three? Well, my guess is that retrograde conduction up the AV node would probably be what this represents if seen consistently. There are also other pacing maneuvers we can use to help differentiate this. But what would explain retrograde AV nodal conduction that occurs so soon after antegrade depolarization? After all, there's a HIS recording that happens just milliseconds beforehand. Well, the presence of dual nodal physiology may explain this. Antegrade conduction occurring down the slow pathway, which we can actually visualize by a prolonged AH interval, and rapid conduction retrograde up the fast pathway. This is an example of what we call an echo beat. A beat traveling down the slow pathway of the AV node and then back up retrograde up the fast pathway. It confirms the presence of dual nodal physiology and is the same as one beat of typical AV nodal reentrant tachycardia. Let's take a look at this closer. In dual AV nodal physiology, AV conduction can occur either by the fast pathway or the slow pathway. Here's our fast pathway, and here's our slow pathway. Our fast pathway is located in the region that we typically place the HIS bundle catheter, whereas our slow pathway is typically located more inferiorly in the area of the CS Oz. In normal sinus rhythm, conduction down the fast pathway occurs more quickly than the slow pathway, and thus is typically responsible for HIS Purkinje system activation. Let's take a look here. We can see that a typical sinus beat propagates through the fast pathway more quickly and prevents the slow pathway from coming down the HIS Purkinje system under typical circumstances. A PAC with the correct timing, though, can find the fast pathway refractory while the slow pathway has recovered. Here's our PAC. And if our PAC finds the fast pathway not yet recovered, if it conducts down the slow pathway, it may be able to propagate both down the HIS Purkinje system and back up retrograde up the fast pathway. This is the mechanism of our echo beat, which we've seen here. Down the slow pathway, and then back up the fast pathway. Now, if the slow pathway can recover in time, this retrograde beat going back up the fast pathway may be able to go back down the slow pathway. And thus, typical AV NRT can be established. And here is the recording that we saw at the beginning of this talk of typical AV NRT. Here are some key references for some of the material used in this talk.